Why does an ulnar nerve injury produce a claw hand, and why is the claw worse in wrist injuries than at the elbow? Let's solve this clinical mystery. Hello everyone, I'm Dr. Divya Dasa and welcome back to AceAnatomy, where anatomy becomes simple, visual and clinically relevant. In today's episode of Anatomy in Practice, we will learn how to identify and localize the ulnar nerve injuries by understanding the anatomy behind the clinical signs. Let's get started. Ulnar nerve begins in the axilla as a continuation of the medial cord of brachial plexus and terminates in the hand by dividing into superficial and deep branch. So let's study the course of the ulnar nerve from the axilla up to the hand. Palmar cutaneous branch enters the palm superficial to the flexor retinaculum and provides sensory innervation over the medial half of the skin on the palm. The dorsal cutaneous branch passes dorsally and provides sensory innervation to the skin over the medial third of the dorsum of the hand and medial 1.5 fingers. Then the ulnar nerve enters the palm by passing superficial to this flexor retinaculum, lying just lateral to the pisiform bone. Here the ulnar nerve will be covered by a fascial band which is called as the volar carpal ligament. The space under this fascial band is called as the ulnar tunnel. So just distal to the pisiform bone, the ulnar nerve divides into its terminal branches, that is the superficial and the deep branch. The superficial terminal branch supplies the palmaris brevis muscle and provides sensory innervation to the skin on the palmar surface of medial 1.5 fingers. The deep terminal branch, it enters the Guyon's canal, that is also called as the pisohamate tunnel, under the cover of pisohamate ligament and turns laterally within the concavity of deep palmar arterial arch, and it ends within the substance of the adductor pollicis which it supplies. So this deep branch of ulnar nerve is purely motor and supplies all the intrinsic muscles of the hand, which includes the hypothenar muscles, the third and fourth lumbricals, all the palmar interossei, all the dorsal interossei, as well as the adductor pollicis. Here you need to remember that the ulnar nerve supplies all the intrinsic muscles except the muscles of thenar eminence, that is the thenar muscles and the first two lumbricals. The sensory supply of the ulnar nerve is by the palmar cutaneous branch, which provides sensory innervation to the skin over the hypothenar eminence. The dorsal cutaneous branch of the ulnar nerve supplies the skin over the medial third of the dorsum of the hand and the medial 1.5 fingers. And the superficial terminal branch gives sensory innervation to the skin over the palmar surface of medial 1.5 fingers. The ulnar nerve is commonly injured at two sites. One is at the elbow and the second site is at the wrist. In ulnar nerve injury, we see both sensory loss as well as motor loss. The sensory loss is mainly over the palmar and dorsal surface of the medial third of hand and the palmar and dorsal surface of the medial 1.5 fingers. The motor loss we see are the loss of abduction and adduction of fingers, the loss of adduction of the thumb, as well as atrophy and flattening of the hypothenar eminence. Now let's look at the injury of the ulnar nerve at the elbow. The injury of the ulnar nerve at the elbow may occur due to fracture dislocation of the medial epicondyle of the humerus, or it can be due to the thickening of the fibrous roof of the cubital tunnel, which we call it as the cubital tunnel syndrome, or there may be compression between the two heads of the flexor carpi ulnaris muscle, and it may also be due to valgus deformity of the elbow. which is known as the tardy or late ulnar nerve palsy. So these are the common causes of injury of ulnar nerve at the elbow. The characteristic clinical features seen in injury of the ulnar nerve at the elbow include atrophy and flattening of hypothenar eminence, because the three hypothenar muscles, that is the abductor digiti minimi, the opponens digiti minimi and the flexor digiti minimi, are all supplied by the ulnar nerve, the deep branch of ulnar nerve. Then we have claw hand deformity affecting the little and ring fingers. This is because of the paralysis of the interosseous muscle as well as the lumbricals. So interosseous muscle, they cause flexion of the metacarpophalangeal joints, and the lumbricals, that is the medial two lumbricals here, they will bring about extension of the interphalangeal joints. So these are paralyzed and it results in claw hand deformity. Then there is loss of abduction and adduction of fingers. So loss of abduction is because of the paralysis of dorsal interosseous muscle, and the loss of adduction is because of the paralysis of palmar interosseous muscle, which are supplied again by the deep branch of ulnar nerve. Then there is loss of adduction of the thumb, and that is because of the paralysis of adductor pollicis muscle, which is also supplied by the deep branch of ulnar nerve before it ends. And we see the sensory loss over the medial third of the hand as well as the medial 1.5 fingers, that is on the palmar surface, as well as the dorsal surface of the medial third of the hand and medial 1.5 fingers. So this is because of all the cutaneous branches which are involved, that is the dorsal cutaneous branch, then the palmar cutaneous branch, as well as the superficial terminal branch of ulnar nerve. Now let's study the causes as well as the clinical features of injury of ulnar nerve at the wrist. The ulnar nerve at the wrist is injured due to the superficial position of the ulnar nerve at this side, and it makes it more vulnerable to cuts and wounds. The second most common cause is the compression of the ulnar nerve in the Guyon's canal, or also called as the piezohamate tunnel. Characteristic clinical features of the injury of ulnar nerve at the wrist include the atrophy and flattening of hypothenar eminence, the claw hand deformity affecting the ring and little finger. Here, this deformity is more pronounced than the injury at the elbow, because here what happens is the flexor digitorum profundus muscle is not paralyzed, because the branch supplying the medial half of the flexor digitorum profundus is supplied by the branch of the ulnar nerve. Ulnar nerve supplies it, and that is given before in the forearm itself, before the ulnar nerve enters the hand. So that is why it is spared, and therefore there is marked flexion of the distal interphalangeal joints only. This is called as the ulnar paradox. Then there is loss of abduction and adduction of fingers. There is loss of adduction of the thumb. The sensory loss due to injury of the ulnar nerve at the wrist depends upon the site of lesion, whether it is proximal to the termination of ulnar nerve or it is distal to the termination of the ulnar nerve. So depending upon the lesion, we may see both sensory loss and no sensory loss, okay, based on the distribution of the ulnar nerve and the site of the lesion. Even in distal, if the injury is distal to the termination, we still see sensory loss in certain areas. So let's see where the sensory loss is and where there is no sensory loss. So if the lesion is proximal to the termination of the ulnar nerve, we see the sensory loss over the medial part of the palm as well as the medial 1.5 digits on the palmar aspect. And we will not see any sensory loss over the dorsum of the palm and medial 1.5 fingers. Okay, that is because the dorsal cutaneous nerve is given before the ulnar nerve enters the hand. So that is why the dorsum of the palm as well as the dorsal side of the medial 1.5 fingers is not affected. Whereas sensory loss we see on the medial part of the palm because the palmar branch is given near the flexor retinaculum as well as the superficial branch, okay, because it is proximal to the termination. So superficial terminal branch is also affected and that results in loss of sensory supply over the medial 1.5 fingers. If the lesion is distal to the termination, that is already after the termination, based on whether it is superficial branch or deep branch. So if the deep branch is affected, then there is no sensory loss. Okay, that is because deep branch is purely motor. Only if the superficial branch is affected, then there is sensory loss, and that is only over the palmar surface of medial 1.5 fingers. Ulnar claw hand is also known as the partial claw hand because it affects only the little and the ring finger. And this is due to paralysis of the interossei as well as the medial two lumbricals which are supplied by the ulnar nerve. Now, why this deformity occurs? Now we have to understand here that the lumbricals and the interossei, they flex the metacarpophalangeal joints and extend the interphalangeal joint. So when both, that is the lumbricals and interossei, are paralyzed, what happens here? The extensor digitorum, okay, which is coming from the forearm, the tendons, they act unopposed, causing hyperextension of the metacarpophalangeal joint. And the flexor digitorum superficialis and profundus, they act unopposed, causing flexion of the proximal interphalangeal and distal interphalangeal joints, and this produces the characteristic clawing of the fingers. Now let's understand partial and complete claw hand. The partial claw hand is nothing but the ulnar nerve injury, where we see extension of the first phalanges or the metacarpophalangeal joints and flexion of the middle and distal phalanges or the interphalangeal joints of little and ring finger. Whereas complete claw hand is both ulnar nerve and median nerve combined injury. So when both these nerves are injured, it results in a complete claw hand. And here we see the hyperextension of the wrist and metacarpophalangeal joints of all the fingers as well as flexion of interphalangeal joints of all the fingers. So this is known as the complete claw hand. So in complete claw hand, there is injury of both ulnar as well as median nerve. What are we trying to do here? We are clinically testing for the ulnar nerve. We are actually looking out for a sign which is known as the Froment's sign. So normally when a card is held or a paper is held between the thumb and the index finger, the thumb is adducted and we hold the paper. So this is the normal state. But in the patient having the ulnar nerve injury, when we ask them to grasp the card between the thumb and index finger on the affected side, and when the doctor tries to pull, there is flexion of the distal phalanx of the thumb. So this is known as the positive Froment sign. So because there is paralysis of the adductor pollicis, because adductor pollicis is supplied by the ulnar nerve, and because of that the thumb is unable to adduct, and because of which there is flexion of the distal phalanx of the thumb to hold the paper when the doctor tries to pull it away. So that we call it as the positive Froment's sign. We also do this Froment's test to see the integrity of the palmar interossei muscle. So we held the paper between the fingers, okay, between the fingers, and try to pull the paper. And when we try to pull that, right, we try to pull that and we look for the integrity of palmar interossei muscle. So here when we do the test, the wrist should be dorsiflexed to rule out any action of the long flexors of the fingers. And that brings us to the end of today's episode of Anatomy in Practice. I hope this video has helped you understand not just the different ulnar nerve injuries, but the anatomical basis behind each clinical presentation. Remember, clinical anatomy is easiest when you understand the why, not just the what. If you found this video helpful, please like, share and subscribe to AceAnatomy, and don't forget to turn on notifications for more simple, visual and clinically relevant anatomy videos. If you have any questions or suggestions for future episodes, leave them in the comments below. Thank you for watching. I'm Dr. Divya Desa. Until next time, keep thinking clinically and keep acing your anatomy.